presented by Dr. Kalyan Roy, Specialist Transfusion Medicine, Square Hospital.
Thank you and good morning, everyone. And it's an honor and privilege for me to be here to present about rotational thromboelastometry. And the title of the presentation is Rotational Thromboelastometry, a paradigm shift in patient blood management. And I would like to start with the patient blood management. So at first, we'd like to know what is the patient blood management. Patient blood management is a multidisciplinary, timely application of evidence-based medical and surgical concepts designed to improve patient outcome by maintaining hemoglobin concentration, optimizing hemostasis, and minimizing blood loss in an effective to improve the patient outcome. So the PBM concept was highlighted in 2010 by the World Health Assembly as an important concept to improve patient safety, and all WHO member states were requested to implement this concept in a timely manner. So what are the situations we usually face in case of the acute hemostatic disorders? When and in which patients? And most often we find it in peri and post-operatively, cardiac and vascular surgery, transplantation, and others like acute coagulopathy, surgery, trauma, hemodilution, etc. So what could be the consequences of these acute hemostatic disorders? So that will increase the morbidity and mortality and use of potentially infectious blood products, and that can also lead to volume overload or even intrally, and prolonged stay in the hospital, ICU, and high treatment cost. So a targeted therapy is a very desirable one. So these are some basic physiologies we have already known from our beginning life, that when there is an injury occurs, there will be a primary hemostasis, secondary hemostasis, and followed by fibrinolysis. And this is the coagulation cascade containing the extrinsic and intrinsic pathway as well as the common pathways. I will not go in detail with these things. So when a patient is bleeding, the surgeon or anesthesiologist must decide on the therapy. The decisions have to be made rapidly in a situation when minutes count. So what questions are going inside the mind of an anesthesiologist or a surgeon? We have got a lot of products. So what to give, like, fresh frozen plasma or platelet concentrations or PDMPs or desmopressin, aprotinin, and how much to give, how often to give, and is it effective if we apply those things? So the treatment of bleeding is to stop the bleeding and to avoid the thromboembolic events, to reduce the transfusion requirements and transfusion-related adverse effects, to save patients' life and hospital cost. So here we got a solution, and that is the rotational thromboelastometry, or we can call it a ROTEM, and this is a point-of-care patient blood management. So what is the ROTEM? ROTEM that I have discussed before, that is a rotational thromboelastometry, and it is an improved method developed in 1990s. Basically, in the past, we used to do the TEG or the thromboelastometry, and that is the updated version of the thromboelastometry that is called a ROTEM. And vasoelastic TEG sting is the methodology to measure and analyze the viscosity of the blood during clot formation and lysis. And thromboelastography, it was, original method founded by Professor Hartrecht, 1948, Munich, Germany. So this is the machine, we call it ROTEM Delta. And this machine looks like a kind of a desktop computer. So it's quite portable, and it's a point of care machine. So at first, we'd like to know about the principles of the thromboelastography. What happened in thromboelastography? There would be pin and a container that will contain the whole blood, and it will go clotting and the further activities, and that will give a pressure to the pin, and this pin pressure will do a motion on the graphical surface, and that will continuously registered in the computer. So what happens in the ROTEM or the latest version of this thromboelastography? Here, the pin will rotate on that thromboelastograph that where we used to use some cup, and that cup has to be rotated. But here, the cup will be stabilized, but the pin, the sensor actually, the sensor pin that will rotate, and it will generate some pressure, and that will be calculated through the lead light, and finally will be processed by the computer, and will be presented in a graphical manner actually. So PBM and the ROTEM results in a lot of advantages, like the reduction in the transfusion requirements, shortening of intensive care unit hospital stay, improvement in patient outcomes, and reduction of hospital costs. So we can understand by this flow, right? The reduction of the hospital length of stay up to 16 to 33%. Then reduction of the reoperation rate was up to 43%. Reduction of the hospital readmission rate was up to 39%. Reduction of RBC transfusion up to 10 to 95%. Reduction of morbidity up to 41%. Reduction of infection rate was up to 81%. Reduction of total hospital costs up to 10 to 24%. And reduction of mortality up to 68%. So the bleeding assessment and the therapy with the ROTEM test, it will take almost 10 to 15 minutes, and thromboelastometry can discriminate between the surgical bleeding and a coagulopathy, goal-directed therapy and therapy monitoring. Thromboelastometry provides a comprehensive information about the hemostasis, avoidance of unnecessary blood products, which is very much important for the patient blood management factors, and patients get the right blood products in the right doses, and that need to stop the bleeding actually, and monitoring of the reversal therapy like protamine. So the detection of the ROTEM, the principle I have mentioned before, that the movement of the axis or the sensor pin and generation of a thromboelastogram. So this is actually a thermogram. We call it a thermogram, the graphical presentation, and that consists of several things like the clotting time or CT, and then the clot formation time or CFT, maximum clot firmness. We call it A5 or alpha angle, maximum lysis index at 30 minutes, and lysis onset time. So this is the graphical presentation, and there are certain tests of the ROTEM like XTEM, INTEM, FIBTEM, APTEM, and HEPTEM. So what does XTEM indicates? It indicates the clot formation, fibrin polymerization, fibrinolysis via extrinsic activation. INTEM is by the intrinsic activation, and FIBTEM, analysis without platelets, qualitative assessment of fibrinogen status. And APTEM indicates that the assessment of the possible effect of antifibrinolytic drugs, and HEPTEM, the specific detection of heparin compared to INTEM. So this is a thermogram actually. The normal thermogram of a normal patient looks like. We get the XTEM, INTEM, FIBTEM, and the APTEM. So these all are in a normal range. So in case of the XTEM, the activation of clot formation by the tissue factors, like we can assess the factors 7, 10, 5, 2, 1, like fibrin, platelets, and fibrinolysis. INTEM, activation of the clot formation via contact phase, assessment of factor 12, 11, 9, 8, 10, 5, 2, 1, fibrin, platelets, and the fibrinolysis. And ROTEM tests, that is the XTEM actually. Here we have seen patient scenario, actually, patient 1 and patient 2. So in the patient 1, we see that the MCF or the maximum clot firmness is quite low. And in case of the FIBTEM, like the purple color below, where the patient 1, that the FIBTEM is indicating it's a normal range, within a normal range, and the patient 1 actually normal result. So there will be no requirement of the FFP or cryoprecipitate or fibrinogen. But in case of the patient 1, we saw the MCF was low, so we can use the thrombocytes. So this is the graphical presentation, and that can help us to do a rational using of the blood and blood components for the patients. Like patient 2, there is the fibrinogen level is very low. In the patient 2, we see there is no purple color graph presentation in the patient 2 slot. So that indicates that the fibrinogen level is very low. And we have to use the fibrinogen or cryoprecipitate or FFP here. So in case of this is actually the APTEM, and where we can see that the fibrinolysis is happening, and in vitro fibrinolysis inhibition. So assessment of the possible effect of antifibrinolytic drug. So the upper graph is showing that there is a hyperfibrinolysis, and when we apply the antifibrinolytic drugs, and the graph on the downwards just coming towards the normal. So we can also assess when and how to use the antifibrinolytic agents here. So here is another thing, that a significantly shortened clotting time in HEPTEM as compared in INTEM is an indicative of heparin effect. So in the upper graph, we can see there is the long clotting time in the upper graph, but on the lower graph shows a picture of the hemostatic situation after inhibition of the heparin effect. So that is the clotting time is becoming towards normal. So these are some interpretations like hyperfibrinolysis, platelet deficiency, etc. So these are the graphs that can help us to understand what to do and what products to use. These are some parameters. We have to calculate those things, though we are not too much expert, because the machine is supposed to be calm, and we'll get some trainings from the patient, from the vendor. So further learning is required, actually. And finally, what is the summary of this presentation is that in a clinical perspective, we can stop the bleeding quickly by providing targeted information, reducing the risks of associated with transfusions, better clinical outcome, and improved patient comfort. And on the other hand, the financial perspective, better utilization of existing OT or OR theaters, shortening of the staying of the hospital, and reduction of the transfusion requirements. We can reduce the morbidity and mortality, and we can lessen the costs as well. So I'd like to conclude my presentation with a quote of Helen Keller, that alone we can do so little, but together we can do so much. So I really do appreciate our teachers and Dr. Pushanta sir and sir, you also, to invite me here, and having the initiative to bring something new in the nation. Because if we get the ROTEM, this will be the first ROTEM in our country. And thank you very much, sir.